Good evening, everyone, and thanks to the Academy of Lung Cancer to not only giving me the chance to speak to all of you, but also to highlight this important topic, which leads to enormous amount of morbidity in patients with lung cancer. And in about next 15 minutes, I would try to highlight the salient points and the features how we try to manage surgically these lesions. So we all understand that the cancer burden is increasing, and it's a cause for massive cost, not just in India but across the globe. And metastatic bone disease and the treatment of this accounts for about 20% of the cost involved. And this is all across that the skeletal related events, which causes a lot of issues and causes involvement of various therapies and cost, which is related mainly to the radiation of the bone, the treatment of hypercalcemia, the management of pathological fractures, various kind of resection bone surgeries, and obviously the metastasis of the spine, contributing and adding to the cost of these lesions. And ultimately, we need to understand that if we can prevent these lesions, we can actually decrease the cost of these treatment, and maybe shift the paradigm from more surgical to more conservative, where the costs are a bit less. And the same thing is available in the India, where the data has shown that we is going to have lots of patients with bone metastasis, which require a great deal of management. Lung cancer accounts for about anywhere between 14 to 30% of skeletal metastasis presenting to any tertiary cancer centers. Or I have put this figure especially for the women group because these numbers are less here, but you can imagine that when we take account for the males, the numbers are still very higher, and hence we know that about anywhere between 20 to 30% of the lesions which we see will be coming from lung cancers. And there are some data just to highlight the same amount of issue, that the kind of the lesions which we see in the bones require various sort of treatment. It increases morbidity and requires surgical as well as conservative management in terms of radiotherapy and medical management, as Priya highlighted to you. But before we go further, what we need to understand that a pathological fracture caused by any metastasis, whether it is CA lung or something, it is not an emergency, and this we all need to understand. We need to evaluate our patients in a great deal, and I will show you a few examples which will again highlight this, that how evaluation can change the kind of management you do to a patient. It anyways need fixation, so you can plan. If you have isolated lesions, then can plan a biopsy, prove the lesions, and then go ahead with the management. The local management per se will not impact the prognosis of the disease, and once it is stage 4, the cure becomes impossible. But yes, as Priya highlighted, and as my colleagues and the team led by Dr. Kumar Prabhash are doing a great job in TMH, we are increasing the survival of these patients with this deadly disease more and more. So again, to highlight that the burden is increasing more and more, and lung is again a common tumor which leads to skeletal metastasis. Lytic lesions are most common. So about 90% of the lesions in CA lungs are seen as lytic lesions, which many times can get confused with various benign or other malignant lesions, and hence the diagnosis has to be perfect. In some patients, we see a mixed lytic and blastic kind of lesions, but predominantly the lesions which are seen are lytic. Spine is the most common site for the metastasis in CA lung, and followed by proximal femur, humerus, and pelvis. But what is very important to understand is that CA lung also throw metastasis to the distal sites. Typically, we say that if you have a skeletal lesion which is beyond the elbow and the knee, it is rare to be met. But whenever it is present, CA lung comes as the first diagnosis of differentials. Pain is the most common thing which the patient presents with. Along with that, there may be increase in the pain on weight bearing, which tells us that the integrity of the bone is compromised, and we need to be very careful with these patients. And these patients do fracture a lot and present to us with pathological fractures and inability to walk as well, but pain is the most common symptom. I have specifically kept these few slides to highlight that many a times I see in my practice that a lot of CA lung patients present to us only as bony lesions and where the primary is not known, and hence we need to evaluate these patients in a particular way. So this three in clinical of orthopedics, which talk about a systematic or a step ladder pattern, how you need to evaluate a bony met lesion for an unknown primary. But what has happened different in last 1 decade is that PET scan has evolved in a great way, and that step ladder pattern, which used to take about 2 to 3 weeks of time, we have reduced it into days, and where we can assess the primary as well as the skeletal lesions, and hence the step ladder pattern has changed dramatically, and now PET scan has become one of the foremost investigations case of bone metastasis. There are various articles which talks about the role of bone scan and whole body MRI, but I think this is just a theoretical discussion. PET scan remains the state of art of investigations, which should help us to evaluate the primary as well as the skeletal metastasis. Another important point which we need to understand, that there are a few cases where in a known case of a primary you can get secondary sarcomas as well. I have had couple of patients who had CA lung and then they had sarcomas in soft tissues as well as in the bone. So one must be careful when evaluating a solitary bony lesion or a solitary soft tissue lesion, even in a known case of previous malignancy. And there are articles which talks about that this percentage is ranges between 5 to 17% depending upon the histopathologies, and hence in these patients, if you have any doubt, if you see the solitary lesions, you must ensure that you clinch the diagnosis by doing a biopsy. When it comes to the treatment, the foremost goal is to have the relief of the pain. We need to ensure that pathological fracture or an impending fracture, we must stabilize, or we must ensure that it doesn't fracture. We need to make sure that the patients who come to us with this morbidity should be functional and should be ambulant as early as possible. And rarely, in some instances, we might have to do the resection of the entire bone to make sure that the mobilization happen immediately and we improve the quality of life. Coming to the surgery per se, we need to treat them, but obviously we must not forget that it's a multidisciplinary treatment, and hence discussion with the colleagues from the medical oncology and radiation oncology department is essential to have the optimum functional and oncological outcome for these patients. Priya very nicely elaborated about the non-surgical or the conservative management lines, but just to add a few is the adequate amount of bracing to give them the pain relief. We can do embolization in patients which are pretty vascular. Role of bisphosphonates she has highlighted very nicely, and hormonals and drug therapies are also covered. Coming to the operative treatment per se, it will be guided by various factors, and these will be: number one, the biological activity of the lesion, how aggressive is the disease, and our surgical management aggressiveness will be inversely proportional to the biological aggressiveness of the disease. Anatomical location will change the way you manage these lesions. The diaphyseal lesions of the long bone will be treated differently as compared to the osteoarticular lesions or periosteoarticular lesions, and I will show you some examples. Obviously, as she alluded very nicely, that there are a lot of molecular tests, and we have EGFR mutations which are better prognosis. So the response to the medical and radiotherapy also governs the kind of surgical management you execute in these patients. And last but not the least, we all understand that the patient's overall health and survival and compliance will guide us to what kind of management we need to do. We also need to consider some patient-related factors like patient's general health, expectancy, whether it's more than 6 weeks or less. If it is anything less than that, we obviously do only conservative management. And whether we need to ensure that the kind of surgery you are going to do will benefit the patient, and the benefits will weigh far better than the conservative management. And the quality of the bone, the remaining bone itself per se, is pretty good to hold your reconstructions. And this kind of surgery will help you to rehabilitate these patients. So these factors must be ensured before you take on to any surgical kind of management. This is one question which comes up in all MDTs. Fracture has not happened, but do we need to do something before it fractures? And that's what called as prophylactic fixation. And Merrill's rating system is a decades old system which has stood the test of the time, which talks about the site of the lesion, the kind of pain patient is having, whether the lesion is blastic, mixed, or lytic, and what the size of the lesion in terms of the circumference of the bone. And this scoring system tells us that if you have score which is more than 9, that means it has a very high susceptibility of getting fracture and must be prophylactically fixed. And if the scores are less than 7, then you can try conservative management for these patients. And this score has been tested multiple times over decades and have stood the test of the time, and now is the mainstay to decide about prophylactic fixations. When we talk about the fixation, we must ensure that we fill these cavities with various agents, expecting bone to heal in these patients, and hence curettage of the lesions using adjuvants and putting cement becomes the mainstay. We also need to ensure that we don't just do the curettage, but we support the bone in a nice way with appropriate implants so that the bone becomes strong enough to bear the weight of the patient, and patient can do functional activities as soon as possible. And these are few examples for the same, and I've shown that the recently developed locking plates, the strength of the locking plates is much higher as compared to the usual ancestral plates, which doesn't give way, and hence these are more popular today to be used. Another big question comes to the mind of all orthopedic surgeons or in MDT is, if you have a fracture in the periarticular or juxtaarticular area, should we try to fix it or should we replace it with a prosthesis? And the answer is very clear here. It depends upon the kind of disease you have. If I have a myeloma patient, I know that I have very, very high chance of healing of the bone by medical therapy and radiation oncology therapy, and hence these patients are more treated conservatively as compared to other lesions like breast and the lung, where the healing of these fractures are extremely low, and hence a replacement is preferred in these patients. And these are various articles which clearly talks about that, especially in the proximal femur, if you have a fracture, the healing rates are very low. Even if you put the nails with cement, they tend to fail over a period of time, and hence replacement better options, specifically lower limb. Upper limb behaves slightly differently. One should also remember that just looking at the fracture is not the right thing to do. We must ensure that we scan the entire bone, and the lesions in the entire bone should be fixed rather than just having a telescopic vision and fixing only the fractures. Some common error happens in the management, and I would like to highlight it here, is some few of the orthopedic surgeons underestimate the life expectancy of the patient. And this typically happens in lung cancers, where they feel that the prognosis is very poor, but we know that now we have various mutations, and for them we have the effective treatment available, and patients live for years together. And hence we must ensure that the operation should be appropriate and it should outlive the life of the patient, whatever reconstruction which we are doing. We underestimate the bone biology, and hence we must ensure that the construct which we are trying to do, the kind of plates we are trying to use, the kind of fillers we are trying to use, should take the load of the patient's body weight and should help us to mobilize these patients immediately. We also undertreat the current disease, and this is what happens when we treat the disease in isolation, and hence an MDT should be there. And hence we must ensure that all lesions in patient's body should be assessed completely and should be treated, and appropriate reference to medical and radiation oncology should happen, and each lesion should be addressed. The last is not planning for the future disease, and this is where we need to know that by not giving additional radiotherapy can lead to again recurrence of the disease or the progression of the disease, and we may be in a disaster, and hence we have to use adjuvants wherever required. Also, we need to understand that many times these lesions are very vascular, especially when they're in the pelvis. And when if we are planning to operate, we must ensure that we have adequate infrastructure available to us to support and take the help of our intervention radiology colleagues to embolize these lesions pre-operatively so that the surgery is more effective and we can have a better outcome. A lot of new treatments are available, and I'm sure these will be covered by Dr. Kunal Gala, but these are sort of semi-invasive treatments where various ablative therapies along with cementoplasty are quite helpful to heal these regions and to have the better functional outcome and avoiding the major morbid surgery, specifically in periacetabular lesion, as you are seeing here. Uh, these are few of the important new things which are coming up, like pain palliation by MRI guided focus ultrasound, or we have HIFU available, which can help to treat these lesions and cure them with the pain. Now I'll show you some cases before I end my talk, and you will be able to see that how differently you can treat these patients. Specifically, first, this patient is a 65-year-old lady. She had a fall at home, and this was the lesion she came with. And when we evaluated her with the help of MRI, this was the lesion. This was the one of the isolated lesions which was there in the level, and we realized that this patient had a breast cancer earlier which was treated, and this biopsy later on found to be an adeno-CA, and most probably was the lung. And so we have 3-4 patients like this where we have the double primaries, and then they were treated with MDT in a different way. So if you get a lesion like that, there are various prognostic scores which can help you to decide what kind of management or what kind of treatment you do. And these have various parameters like what is the primary, what is the aggressiveness of the disease, whether these lesions are only located in the bones or they are in the viscera, what is the ECOG status of the patient, and what kind of previous treatment patient has taken. And based upon that, you have the survival curves available, and depending upon these survival curves, you predict or you predict the survival and do the appropriate management. And in this patient, we do our lung MDT to take care of the lesions. Another patient was a 47-year-old male who had pain in his thighs since long. This was the lesion, and we evaluated this further with the help of a CT guided biopsy, which came out to be metastatic carcinoma. On the PET, there was primary in the lung with nodes, and it was a solitary bony lesion. This was the CT scan, and this was the lesion in the lung, which was picked up on the PET scan. Again, evaluated the patient with the prognostic scores, and we found that this patient has better survival. This patient was treated with prophylactic fixation with the help of interlocking nail, and was treated with adjuvant CT-RT and had a fantastic outcome with healing of the lesion. Another patient, 61-year-old male, who suddenly developed pain in his hip and inability to walk. And this was the lesion of the pelvis, where we see the protrusio acetabulae, where the femur has literally gone inside the pelvis and he was not able to walk. We did the biopsy. Again, this was an unknown primary. It came as metastatic carcinoma, and we followed the usual steps of identifying the primary, looking at the disease burden, and obviously then prognosticating the patient and treat the affected limb. The PET scan showed the CA lung with adrenal, nodal, and brain metastasis. And obviously we know that the treatment which we are looking at must be conservative treatment and should not be embarking on to very aggressive treatment in this patient where prognosis is very poor, and hence he was treated with radiotherapy and he's come to the disease after 2 months. Another very interesting case of CA lung with skeletal metastasis in a 63-year-old male who had CA lung since 4 years. He was treated in Tata Memorial Hospital by Dr. Kumar along the lesser trochanter. This was his PET scan earlier, where he showed the lesion in the femur, and this was his biopsy at that point of time. He had EGFR mutations positive, and he was treated with SPRT to the lung and to the femoral region radiotherapy, and this was complete resolution of the lesion. So again, showing you, highlighting you that how the management and the outcomes in these patients have changed, and over a period of 3 years these lesions were observed. Recently I found that his lesion has increased and he's developed a fracture. When Dr. Kumar referred it to me, we did the MRI again. So the lesion has increased with the pathological fractures, and recently we replaced with megaprosthesis. So again, trying to show that the kind of surgery, the kind of aggressiveness we need to do, it all depends upon the biology of the disease and the fitness of the patient. So I will end here by saying that we all, in metastatic bone patients, we try our level best to cure sometimes and to control most oftenly and comfort always. Thank you so much.